Just okay. Good morning, everyone. Can you share the video, Nuruddin?
Yes, it is shared, Dr. Nagi. We can see your screen.
Okay. Good morning, everyone. As Dr. Nuruddin said, that welcome you to these lectures, which is hopefully we will a series of lectures which will be happen over the next 6 months. And the good news that we have about 7 or 8 consultants who agreed to give you lectures in different specialities. And as you know, that is my specialty is pediatric neurology, but also I will try to give other lectures as well in the communications and mentoring and how to deliver your lectures as well on top of the neurology. And it's a pleasure that is, we started this programs, and I really appreciate very much of you to, if you can, as Dr. Nuruddin said about, if you want any questions, just put them in the chat and then we'll answer them at the end. So, and I'm just going back, sorry, so we're going back to the lecture. This lecture is about the recognizing sick children. The reason I chose this lectures because always when I teach here in UK, new student or new graduate or anyone who joining us in the department, I usually start with this lectures for them because it's important that you recognize a sick patient. And before recognizing sick patient, I'm sure you're familiar with the normal ones. And if you know all the normal parameters for the for children or adults or anyone, then you will be able to recognize this is sick or not sick, bad or not bad. So that's why I always started with these lectures, which is, I think with this lecture, if you have done your ABLS or basic life support, then you will be, it's very easy for you to recognize sick children. So, and hopefully if you haven't done it, then go ahead and do it. So recognize sick children. So the objective of this talk is recognizing sick children, of course, then apply skills to manage these patients and not to miss all signs. I'm not going to give all the management, how to manage sick children, because hopefully I will cover some of it in next lecture. Then my other colleague will cover it as well when going to manage the sick children who either they have sepsis, they have status epilepticus, they have dehydration, they have a cardiac disease, they have respiratory disease, and so on. So we'll leave the management and the investigations to be covered all in our lectures in the future talks. But today I'm just these 3 objectives. Hopefully I can achieve them at the end of the sessions, and I want your feedback on that as well. So why might signs be missed? Just take a moment and think about yourself. Why people they missing the signs of sick children or sick patient in general? So least likely to be lack of knowledge or experience. So some people who just been graduated and been pushed to the accident emergency to see children or adults, they may have lack of experience. They have the knowledge, but sometimes they have the lack of experience. So that's why people who just newly graduated, they shouldn't be left alone managing patient. Or if you are left alone, make sure you discuss it with someone senior. Mostly not following best practice and guidelines. This is for more people who are just a little bit more senior, like in year 3, year 4 of training or registrar post, or they just not following the best practice. And I know the best practice is a big topic, and that you can find it in everywhere in the websites of Royal Colleges or in the website of GMC or and then guidelines, of course. The guidelines is, I hope that is every department where you work, they have a guidelines for everything. I know Libya, they lack of that quite a lot, but I think it's a very, very important. When you're stuck, you can go back to the guidelines, because in a court of law, if you don't have a guidelines, you can't defend yourself if something happens. Usually because early sign of many illness are similar, especially in children. You see them in A&E, they come with fever, vomiting, not well, confused. So a lot of symptom and sign to start with is the same. Poor communication between junior and senior doctors. So sometimes the junior doctors, they left alone managing the ward or A&E, and the senior doctors are not there all the time. So it is better to have a one dedicated senior person every day to support the junior doctors and communicate with them, because if there's any questions, if there's any, they come, then they will help them. Tiredness and lack of sleep. So make sure that is, you don't do long shifts, like 24 hours or 48 hours, and then you go and see some sick patient, because at the time you will be missing quite a lot. So this is why might sign be missed. This is just a nutshell of few things. I'm sure there's others as well. I'm not going to go into details. Now we go through the lectures. So what you need from this when you see someone, you think he's sick or she's sick. So the first thing is, of course, you have a quick history, maybe 10, 15 seconds or a half a minute history, why you are here, what's happened, and then what's happened. So you can, will give you a clue. Assessment, you look quickly, color, response, capillary fill time, respiratory rate, heart rate. And I said, you should know the normal before the abnormal as well, especially when you, for respiratory rate and heart rate, because neonate or someone who's a month old, his heart rate is 150, 160, it could be normal. And his respiratory rate is 40 or 45 or 50, it could be normal. But someone who is 11, 12, his heart rate is 120, 140 is not normal. So examinations, just make sure you expose, always expose the child. It doesn't matter if the parents, they said, then try to expose them as much as you can, because that will tell you quite a lot. You see the pattern of breathing, you see if there's any rashes, you see any bruises, and that will help you quite a lot. Skin color, is it pale? If you can't, if the skin color is very dark, you can't tell is it pale or not. Look to the tongue, look into the lips, look into the sole of the feet, palm of the hand as well. And the eyes as well will tell you quite a lot if the pupil is reacting dilated or not dilated. Investigation and management, I said I will leave it for the next time. Okay, so the assessment 2 is, and you see A, B, C, D there. This is, and then F, G, H, I. So if you know your A, B, C, D, and E, then that is really the cornerstone of the assessing sick patients. So the airway, make sure it's patent. They can breathe by themselves. If they can't breathe, and what you can do, you can put your ears or your cheek in front of their nose and see if they are breathing. If they are not breathing and there is no chest movement, then you have to start helping them. The breathing, as I said, pattern of the breathing, you can see also to look to the intercostal subcostal recessions, and we'll talk about it later. Cardiovascular, circulations quickly, pulse, we'll talk about, and disability neurology, would they respond or not respond, and then exposure, everything else. So they will be adapted as ANT for scenario. So this is just look for the exposure, because exposure is very important as well. Fluids, the renal, you can ask whether they have wet nappies or they pass the urine, when the last time they pass the urine or vomit. Gastro, if there's any diarrhea or anything, hematology, maybe or maybe not required at that stage, infections, micro or rashes, and then all these things can be done as you're going. But the first 3 or 4 things, A, B, C, D, is the most important one. You can do them in 30 seconds, which I'm trying to teach you today about these 3. So the pediatric assessment triangle. So this is like a gold stone for assessing. So appearance, work of breathing, and circulation to skin. So this is the typical what you should do in the first 30 seconds when you meet any patient. The appearance, abnormal tone, they're lying limp, interactiveness, that they do not interact with you, they don't look to you, they don't respond to you, consolability, they're crying, they are in pain or something, abnormal look or gaze, their eyes just wide open, they don't respond to you, and glazed, and abnormal speech, like gibberish speech or confused, and also crying quite a lot. Work of breathing, abnormal sound, abnormal position, retraction, flaring, apnea, gasping, and then circulation, pillar, mottling, and cyanosis. And then I put just a link there down below, which will be, you can follow with that. Remember, all these lectures will be put on the our YouTube channel, which will give you the link. You can watch them again and again if you want, or share it with your colleague and watch it together, or teach people, other people. You can take it. I'm quite happy for you to use my lecture to teach other people as well. So how to assess a sick child? So I mean, it's a very big question. So I think it's the thing is you need to look to is difficulty in breathing, fever, rash, fits, dehydration, abdominal pain, head injury. So this is the like the headlines. So this is from the Royal College of Pediatrics. There's a really a very good also video, which you can watch it from that link online. And that's really very good to look to all the difficult, they will guide you how to do that as well. So if you have time with these lectures and you go and watch this video, it's a very, very good resource for you as well. Difficulty in breathing, temperature, you have to make sure, rashes, fits, dehydrations, abdominal pain, and the head injuries as well. So recognize potential respiratory failure. This is the most important thing, which is the A-B airway and breathing. So if you go to the airways, as I said earlier, you're looking for is the child breathing by himself or not, or is she breathing by herself or not? If there is no, you're not sure, then what we can see is what we call look, feel, and listen. So what you do, you just put your cheeks on their nose and mouth, just maybe 3-4 centimeters away from it, and then feel any breathing, listen if there's any breathing, and then look if the chest movement or no. So that's the airway. If it's not patent, not working, then of course you put them on the side. If they maybe don't put your finger inside their mouth or anything, they just if they are not breathing, then you give them 5 breaths, either by mask, tube, or by your mouth, or whatever you have. Then move to the next one, which is the breathing. If there is the respiratory rate, count it. If it is below the threshold of the normal, then you help. Recession, intercostal, subcostal recession, especially when there is acute respiratory problem like bronchiolitis, like asthma, like even diabetic ketoacidosis or dehydrated. So breathing will go fast and they start using accessory muscle. Inspiratory or expiratory noises. So if there is inspiratory, which is a stride, or expiratory, which is wheeze, listen to them as well. So that will tell you is upper or lower respiratory tract. Grunting, that is mean difficulty in breathing, which is that mean that breathing against a closed epiglottis. Try to maximize the thoracic pressure, so that is mean the perfusion and the oxygen can go to the lung very easily. Accessory muscle use, especially in the muscle and the neck, and they are sitting up there, you see the muscle there in the neck is moving, and that's something else. All these things is try to prevent uncompensatory phase. Then flare of the LNSI, that means they are up and down, so that is make sure this is happening under the age of 1 year, but of course. And you look to the X-ray, which is very clear. This is a very, very bad chest infections, which could be virus, could be bacteria, mainly on the left side. And that's typical of broncholytic chest X-ray as well. Now, common causes of type 1 hypoxic, which is respiratory failure, because the hypoxia is the most important thing to be prevented, because it's the most causing of the deaths in any sick child. If you don't recognize it and do something. So that's why every child, when they walk to the A&E, they have a problem, or on the ward they have a problem, the nurses, good nurses, first thing they do, they just give them oxygen, because they know if you, that means to help them their hypoxia. And there are many causes, as you can see on the slide, but also there's others as well. I'm not going. And respiratory failure is the early stages. If you don't treat it and give them oxygen straight away, or intubation, whatever you can help them, then they may elapse and they're becoming uncompensatory, and it is difficult. So you know the brain cannot survive more than 3 minutes without oxygen as well. So hypoxia is the most common factor killing patients. So that's why I recognize it and treat it very quickly. Now we just going on the to recognize the other things which goes with the respiratory failure is people, they go and do blood gases, and the blood gases is it's very important, but that can be done later while you're resuscitating the child or helping them. And you can see it's just respiratory acidosis, metabolic acidosis, respiratory alkalosis, and metabolic alkalosis. This is the common 4 things, and then the others is usually they are happening in chronic conditions or on a long problem. But I want you to recognize the top 2, respiratory acidosis and metabolic acidosis. That's the most common ones, and specifically metabolic acidosis with the sepsis and respiratory acidosis with the obstruction. So if you recognize them, and then you know the problems, and then you can help the patient more. So I will, and this is the flow chart for these 2, the gas interpretations and what you're supposed to do. And so always remember these things is it is a very specialist, and if you work in intensive care or in a neonatal unit, you will be familiar with it quite a lot. But in A&E, I think you only need to know if the CO2 is very high or low, or if the base excess is very high or low, and then accordingly you can manage the patient at the time until a senior colleague or intensivists came and help you more with that. Because it's, as I said, it's very, very important. If the CO2 is high, that is mean there's obstruction, there's hypoxia is going to happen, and then you give them oxygen. And if the base excess is very high, or minus like 7 or 11 or 20 or whatever, then fluid until the intensivist came and helped you with that as well. Type 2, which usually related to chronic CO2 accumulations in the bodies, and usually patients who have a chronic conditions, or these chronic condition usually they may have acute, so they may have hypoxia, so acute on a chronic, and there are many causes of it. It's severe asthma, drug overdose, poisoning, anyone who got a very chronic problem affecting the either the chest or the muscles, or in general the body or the brain itself. So that means CO2 in these cases, they are always high, like 6 or 7. So don't, that's why the history is very important. Don't try to put the CO2s like in normal 4 or 5 at that stage. So leave it and then treat the acute phase. So I think, it's, as I said, this is always a senior colleague or intensivist will help you with that as well. But your priority to understand, to find from the history whether this is a chronic condition or an acute condition. The second one, or the third one in the ABCD, is the C, which is recognized circulatory failure. And the circulatory failure, we have 3 things: the heart rate, the pulse volume, the capillary fill, and blood pressures. All of them, I think the top one, heart rate and the blood pressure, is the most important one. And we know that every time when someone who gets a problem is very sick or sick, the heart rate, the first thing will go is the heart rate go fast. The reason for that is the 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 body is the heart try to compensate and pump the blood and everything and oxygen to the vital organs, and also the physiological changes like adrenaline and adrenergic factor, they reduce quite a lot, and then the heart will go high. So try to compensate as much as possible and getting a nutrient, getting oxygen, getting everything to the vital organs. And this is like a reaction of the body. So that's why if there is no fluid, you give fluid and the heart rate hopefully will come down and the blood pressure will go up. So the pulse volume, so that has been the volume when there is fluid redistribution is low in the body, the pulse volume peripherally go low, but centrally still you feel it. So you always, if you can't feel the pulse peripherally, go to the central and feel. Capillary refill is another sign, which is not all the time you need to do. You can do it, but it's not always an accurate measurement. But always, if you want to do it centrally. People sometimes they come and take the index finger and press it for 5 seconds. Like if you don't know 5 seconds, you can say 1 in 100, 1 in 200, 1 in 300, 1 in 400, and 1 in 500, and then take off your fingers from the chest or the sternum, and then do the same thing again. So majority of the time should be less than 2 seconds. The refill is very quickly. If it's 2 to 3 is okay, but if it's 4, 5, 6, 7, that means very bad. Blood pressure, we know that at the beginning, and for anything, it will be high, especially the diastolic, and then within the 5 to 10 minutes, it starts dipping down. If the blood pressure starts dipping down, that is mean the patient is really in a big trouble. You have to do something, otherwise cardiac arrest will happen very quickly. So that's why it is important to recognize the children or the patient in the compensatory phase, which we'll talk about it. Now they recognize potential CNS failure, which I think it's one of the things that is a key component. We will look at each of them in turn. So conscious level. So if you are familiar with the Glasgow Coma scale, use it. If you are not familiar with it, or it's too long. I know it is a 15 point. You have to go through them. So you use this one. It's alert, respond to voice, respond to pain, and responsive. If you respond to pain, that is mean they can't protect their airway very well. So the Glasgow Coma scale will be between 8 and 12. If unresponsive, that means Glasgow Coma scale is below 7 or 8. So that means you have to intubate at that stage. And respond to pain, that is mean really very critical. You have to make sure their airway is patent and protected. If they respond to voice alert, then that means Glasgow Coma scale between 12 and 15. So that means so that means this AVAPU is very, very quick and will help quite a lot and then guide you where to go. And then postures, whether they are very limp, they are decorticate, decerebrate, as well, you need to do posture, because if they are decorticate or decerebrate, that means there is increase in intracranial pressure and there's a herniations in the brain, and then you need to do something, or there's maybe cerebral edema is very bad, and then you need to do so. That's why they posture. Pupils, of course, when you do the assessment, you have to shine the light and see if they are reacting is unilateral pupil dilatation or bilateral pupil dilatation, or sluggish reactions, or they are pinpoint. So and then if they are pinpoint, it could be hemorrhage, could be drugs, could be something else. If they are dilated or unilateral dilated, then there's something wrong with the brain. Don't forget to do the glucose with this CNS failure, because it's become, any child who's become unconscious, confused, I think the first thing you ask the nurses to do the glucose, because sometimes you could reverse them. You don't need to go further. Okay, so that's the ABCD. So I'm not going to the E and the others. I want you to just concentrate on these 4 things. Okay, so as I said earlier, decorticate and decerebrate. Decorticate is the child just flexing the arms on the chest, and this is severe damage to the brain, and best motor response is of 3. This is mean Glasgow Coma scale is below 3, so on the Glasgow Coma, so they need to be intubated. So the legs is very extended and clenching fist in the arm. So decorticate, that means there's a herniation of the brain or medulla down. And the cerebrate is the same thing, just extension everywhere. The posturing is being an indicator of even more serious damage. Both arms and leg are rigid and extended and arched. And Glasgow Coma scale is 2, and this is need intubated. So sometimes they bring like this, whether these things happen because of the bleeding, because of the increase in the cranial pressure in general. And this is for a long time, so they've been left for a long time at home. So that's we done all of that now, the ABCD. Now we're just going to talk about a little bit what the common causes of these things, and you need to do. One of the things which you need to recognize is the shock. Is the child shocked or not shocked? Shock is a complex clinical syndrome that is the body response to cellular metabolic deficiency. So when someone is shocked, so they are mildly agitated or confusion because of hypoxia, so the oxygen is not there, so they are or dehydrated, or because of the septicemia. Skin pallor, so it doesn't mean the skin is very pale, or capillary fill less than more than 2 seconds. Increased heart rate, and cold peripheral skin with decreased capillary return. So all of these, this is a compensatory phase features. If you don't recognize them, if you recognize them here and you do something about it, then you can reverse the shock and you can save them at least 80 to 90% of the patient. If you don't do anything and the patient going to uncompensatory phase, which they're becoming, we'll talk about it shortly, then the death rate will be like 70-80%. So it's important to recognize these features and then do something about it and help the patient at this stage. So shock, so as I said, compensated, agitation or confusion, skill better, increased heart rate, blood pressure may be high, as I said earlier. So don't be fooled about it. So make sure the nurses, they do every 5 minutes the blood pressure and look into the diastolic and the systolic. Then cold peripheries, decreased capillary fill. So that's compensatory phase. This is where you want to be a hero and treat the patient and prevent them going to uncompensatory phase. Because we know that from all the studies, a lot of patients, when they hit the A&E, they usually in uncompensatory phase. And also on the ward, if the nurses are not doing their job right, they alert you, then the same thing can happen. So that's why uncompensatory phase shouldn't happen inside the hospital. But maybe the patient, maybe it happened at home because the parents, they don't recognize it, or they keep delaying, especially in the night. So it's important that is you recognize them there and you save them, 90% you can save them. If they reach an uncompensatory phase, then they will have a lot of morbidity, a lot of mortality as well. So uncompensatory phase, blood pressure start falling, capillary fill more than 5-10 seconds, very cold peripheries, acidotic breathing, which is, you can smell it, especially in DKA, and then depressed cerebral state, that means they not respond to pain, they be unresponsive, and then absence urine output, maybe they told you he didn't. So you can see the two pictures here on the right. The first one is someone who's having a normal color, everything is normal, bright, everything, that's a normal child. And you see the bottom one is really a sick child, very, very sick. And that is about. If you don't do anything in a compensatory phase and you're just watching them and you don't know what to do, then within 10-15 minutes, if the blood pressure starts dropping, then we'll have a cardiac arrest and they will die. So children can compensate for longer than adults. So the compensatory phase for the children is longer. So they give you time to recognize them and treat them. But adults, they don't give you time. They usually lapse very quickly from compensatory phase to uncompensatory phase very quickly. So when the children hitting the uncompensatory phase, it is very hard time. They will give you very hard time. So that's why they give you time to recognize them. If you don't, they go to uncompensatory and you will be having hard time for that. So causes of hypovolemia for the shocks, there are 5 types of 5 types of shock The first one, hypovolemic, which either losing of the volume, or whether there's bleeding, dehydrations, polyuria, dysuria, or distribution is in the body is not equal. Then you have the distributive. Usually distributive does mean the fluid is still the same, and they didn't lose it, but it's not equally distributed in the body. And the commonest cause of this is the anaphylactic shock, sometimes sepsis as well. Cardiogenic, that means the pump is not working properly, that doesn't deliver the fluid to the body and oxygen, and the cardiac diseases is the commonest one, or compensatory phase. Obstructive is the same thing, that is there is an obstruction, whether there's a cardiomyopathy, tamponade, pneumothorax, everything is so this means the blood or the distribution of the volume it is not equal in the body. Dissociative is the same thing, that means usually associated with CNS failure or cardiac, and that is mean the volume still the same in the body, but it's not being distributed, especially when they have like heart failure or liver failure or kidney failures. So that's the 5 types of shock, which is you need to recognize when you're dealing with someone sick. And everyone is different in management and investigation. So that's hopefully will be covered in the next few lectures. Now, dehydrations, I'm sure you're familiar with it. Mild, we don't see them a lot, but moderate is the commonest coming to the A&E. And then if there's about 10% of the patient who dehydrated, they go to the severe dehydration and may hit the A&E, especially if the parents, they don't bring them quickly and they said, wait till morning or wait until the father come and take them, they don't have transport. So it is important that is, you recognize them and treat them, and then also to educate parents about it. If they start moderate, so they give them a small amount of fluid, then they may be not going to the severe one. The commonest cause of severe dehydration is gastroenteritis, but the other one commonest is DKA, diabetic ketoacidosis. Dehydration, you can see this is a severe one. Top is very bad. When they're treated and they are given a fluid, you see the skin is very shiny, they are alert, they're different pictures. So the first one is very sick, and the other one is not very sick. Just to give you a case to think about it, Fatima is 2 years old, brought to the accident emergency as she is very agitated, crying, and her breathing has funny smell. So her heart rate is 150, respiratory rate is 40, all of them is high, capillary fill 3 seconds. Is she shocked? What do you think? Write it down. I will give you the answer. Is she in compensatory phase? What next one test you will do? So, yes, of course, she's shocked, which is circulatory failure, circulatory shock, so hypovolemic. Is she? Yes, she's still in compensatory phase because capillary fill is less than 3 seconds, heart rate 150, respiratory, so blood pressure is not there. What one next test you will do because of the funny smell? So people, they feel acetone. So it could be DKA. Diabetic ketoacidosis is the commonest thing is here. So that's why I give you the funny smell as the clue. So that's why is all the time is this kind of scenario, you do it between yourself and there's a lot of them in the literatures and you can look to them. So it's very important that is you recognize, is she shocked? Is she compensatory? Because if she compensatory, I could save her and do something. If you don't do anything and you should, just wait until my colleague comes or I have a chat with my colleague. No, do something at that stage. You have to act, because otherwise they give you only maybe 10, 15 minutes and then they go to uncompensatory phase and it will be difficult to get them back. Okay, the commonest subject, which is very, very, very becoming now the hot topic in pediatric or in adult, is sepsis. Sepsis is the most common cause of death now among the, especially in the neonatal period or under the age of 1 year. Sepsis is a clinical syndrome resulting from dysregulated immune response to infection. It does not mean they have an immune problem, but just because overwhelming, the bacteria is taking over your immune system or taking the over immune system of the body, cannot fight it. And because so quick, so vicious, it will like block the immune system, unfortunately. An immune system is not react very quickly. The first our defense mechanism is a white cell, but the white cell sometimes cannot do much, especially in neutrophils. It is characterized by the arrangement in multiple pathological process, which may lead to widespread tissue injury. So because of the body and the attack of the bacteria and killing everything, so the body will produce toxin, and the toxin can cause damage to the tissue, to especially the heart and the brain and the blood vessels and everything. It is encompass a clinical spectrum of severity, including severe sepsis, septic shock, and multi-organ failure. As I said, sepsis is leading cause of vulnerability and mortality in children worldwide. And if you want to read about all of these four, I put some links down and you can read them. It is, as I said, sepsis is becoming quite a lot. And I think is, if I will give you one task, you want to do it over the next maybe week or 2 weeks, just draw a flow chart and stick it in your office or when you go, and share it with your colleague how to recognize sepsis, how to treat sepsis. And then if you are even clever enough or want to do something, design a leaflet and give it to the parents as well, and the GPs and everyone to recognize these sexual. So this is one task I would like you to do if you want to do it, and then I'm quite happy to share, if you can share it with me as well. History of an examination in sepsis is very important. Key diagnostic factor, presence of risk factor, fever or low body temperature, tachypnea, tachycardia, and many rashes, mottling. So this is all key diagnostic factor. Other diagnostic factor, hypotension, specific focal sign and symptom reflecting underlying pathology. So you look to every organs, and as I said, A, B, C, D. That's the 4 things. That's other diagnostic factor. Risk factor, immune deficiency, comorbidity, male sex, younger age, especially neonates. So immune deficiency, people who have immune problems, people who have chronic conditions, and then they said more in males than in females. We don't know why. Younger age group, especially neonate. And neonate is the most difficult to recognize because they go very quickly. Okay, so we have 5 minutes and then we will go to your questions if you have any questions. Okay, I just have a quick video here. This is someone who, you see, there's a very bad infections on the ears and on the scalp, and he underlying is the eczema. And he got eczema herpeticum. And this eczema herpeticum is the one of the things which can flood very quickly. And if you don't do anything about it, it's very bad. Because one thing which is, I learn it all the time, they lose quite a lot of fluid and become dehydrated. So make sure that they have a fluid on the board, they have treatment on the board, like any other sepsis. So it's a virus and it can be affected. Diagnostic investigations in sepsis. Of course, you know them. I'm sure you're familiar with them. Consider lumbar puncture, meningococcal polymerase chain reaction analysis, BCR. Yeah. Bronchoalveolar lavages being intubated because sometimes it's very good for virology. Herpes simplex virus, polymerase chain reactions. Yeah, it's very, very important. So consider these if you have them. And then emerging test serum calcitonin and emerging biomarkers and phenotest BC kit. This is all a marker, like we depend on CRP. But now these things is resembling the SRB, but specificity and sensitivities, it's much better. And they will tell you this is a bacteria rather than a virus. So you need to familiar with yourself. I know it is the emerging test is not available in Libya at the moment, or even in here in UK or other places, only intensive care sometimes they do it. But just do your basic, the one which is first an investigation to be considered using CRP. Okay. Sepsis, early septic shock or compensatory phase, as I said, early raised cardiac output, warm extremities, wild pulse, pressure, mental confusion. So this is when you would like to recognize the children in sepsis or in neonate. If you recognize them there, give them antibiotic, fluid, intensive care, then they survive. If they go late septic shock and they become uncompensatory, then they go to these things, and they don't give you time. If you don't do anything, even in uncompensatory phase, they have 30 to 40% chance survivor and a lot of comorbidity, then ultimately will be dead. And then really, if you want to read more about, there's a really very good guidelines, which we call NICE, National Institute of Clinical Excellence in UK. They produce a lot of guidelines, and one of them, the sepsis, please go and look to them. And that's where I want you to draw a sepsis recognition chart for your colleague and yourself and your student and everyone. And then if you do a big one and stick it in A&E where you manage the patient, people, they will thank you about that. Okay, this is the rashes. I'm sure you know this is really I'm sure you have seen it in either, if you don't see it in live, you can see it on photos. This is meningococcemia. It is the killer of the patient. I know that is there is a vaccine for type C and A, but B, you don't have it in Libya, and B, we have it here in UK now, the vaccine. We don't see any more of this type of meningococcemia or Neisseria meningitis. But hopefully in future, the government or the Minister of Health, they will bring this vaccine, so you won't see this horrible disease anymore. Don't forget, hemophilus influenza, pneumococcus can cause the same, but usually the Neisseria meningitis is the bad one. And to recognize it, to teach the parents how to recognize the rashes, glass, just stick a glass on it. If it disappears, okay, and if it doesn't, then this could be a purpura crash and they need to see someone, okay? Seizures, compensatory, raise cardiac output, feel warm, blood pressure normal or high, unconscious. So seizures always, as a fact, anyone who loses conscious and have abnormal movement is epileptic seizure. Anyone who doesn't lose conscious and they have a seizure, they are not epileptic seizure. Uncompensatory phase, which usually, that's why we'll talk about it next time about status epilepticus. If you don't treat it within half hour or within an hour, this is what is going to happen, uncompensatory phase, and people, they will have a lot of problems. Now, pain in children is another thing. Is always when you deal with the children, when you want to go and help them and recognize they are sick or not, remember they feel pain. So explain whatever you want to do if they are alert and conscious. It doesn't matter. They understand or they don't understand. If they are under the age of 1 year or 2 years, exactly, talk to the parents as if you are talking to the child. It doesn't matter. It's very important. This is a communication, trust, and everything. Use local anesthetic if you can. If you can't in emergency, sometimes you don't need to use it, but if child alert and conscious, give them time. Use the anesthetic, local either spray or cream. Give analgesic pain, especially someone who has a broken arm and bleeding, or involved in an accident and bleed and have a broken arms or legs or bones, then use the analgesia. We don't do PR in children. I never done it. Hopefully you don't do it. Pediatric early warning scores. This is another thing which is becoming very, very hot. And then I put the BMG website, the link. Please go read about it. This is a score. It is, you can do it yourself. When you do the sepsis flow chart, you can do the same thing, do the score. Early warning score are generally defined as bedside track and triggers, tools to help alert staff to clinically deteriorating child. So this is, you can draw it or print it from this website and put it to the nurses, because the nurses is the people who on the ward. The nurses who will meet the child when come to the accident emergency. So teach your nurses to know the early warning sign. And then the nurses will tell you if the child is very sick, and they help you with that. So it's very, very important. Go and have a look to it, print it, teach your nurses, teach medical student about it, teach your colleague. So when you teach them and that's why I said there's a good practice and following guidelines, then you will recognize a lot of sick children, a lot. And then you will save a lot of lives, and you will feel satisfied with your job. I know in Libya at the moment, the training and the people have no time to teach you, to guide you, to take your hand. But I think with such a webinar, and we do what we're doing, we try to get the message to you and your colleague to do this. There's a lot of things on the website, on the internet. There's a lot of things, hopefully will come from our lectures. And then at one day, hopefully you also, for yourself and your colleague, to transfer your knowledge and skill to your student and others. Now, just before we go, I just want to, another case. Ahmed is a 2-month-old baby coughing for 2 hours of feed and crying more than usual. Any cause for concern here? I just want you to write 2-3 things. Anything concerning you here? Is he sick or not sick? So 2 months old, coughing for, 24 hours, not 2 hours. Sorry, it's a mistake. 24 hours. He's coughing for 24 hours of feed and crying. So, sure. Any cause for concern is, so the concern here is, there's a lot of concern here because the baby is 2 months, he's coughing for 24 hours and off feed and crying. So there's a 4 thing. Off feed, babies, they never go off feed if they are well. The first thing you can ask the parents, is he feeding well or not? They said, oh, he didn't feed for the last 6 hours, or refused to feed. So babies under the age of 1 year, one thing they will never give up is, or give it away, is the food. So this is alarming for you. And then 24 hours coughing, baby crying. So is he sick? Yes, of course. This is sick and he's in compensatory phase. So you need to do something. So this is typical of someone who's got a bronchiolitis or maybe pneumonia or maybe pneumonitis, especially we have now the coronavirus and things. Okay, hopefully you get it right. So I've just finished with this stage, a rapid assessment. This is, you can do it exactly. I teach people to do it in 10 seconds. Airway and breathing, circulations, disability. This slide, it is summarized what we have all the last 45 minutes we're talking about. So take a look to it, take a photo of it, and then draw your chart as we agreed, and then hopefully we will meet next time. So as I said, next lecture is the States Epilepticus, 5th of June, same time. Thank you. Now we go back to Dr. Nuruddin, and then he will read the questions. And if you have haven't wrote questions or comments, please write them now and on the chat, and then I will answer as much as possible. And don't forget, please do the feedback, because it's very, very important for us to do that. And also remember, we will put this talk on the YouTube channel, and we'll send the link to all of you who attended today. Thank you.
Thank you very much, Dr. Nagi. That's a lot of information. And let's see if we have any questions. I think some of us who are using mobile phones, maybe they don't see the chat icon, so please try to find it so you can type your questions here. I've actually started my video, but I don't think you have to see me. So let me just stop my video. I'll just leave the mic. So there's a few questions here. Dr. Nagi, one of them is quite long. This will probably require you to read it, please. If you open the chat.
Let me get out from this.
You can stop your video if you wish. You can stop screen sharing.
Yeah.
And there's one at the top. I can copy and paste it again. It's quite long. He says, somebody works in peripheral hospital. Children come to me with difficult breathing. When he examines the chest, there's wheezy chest, oxygen saturation is 88%. He is type 1 DM, sugar is 180. Da, da, da. It's too long for me, so I'm not a specialist. So probably it's better if you read it.
Which one?
By Muhammad Al-Daifi or Daifi, something like that. If you go up.
Oh yeah, if I work in a hospital and children comes
exactly.
to
Yeah. If you go to
is 88% and he's type 1 diabetes. This is DKA, so it's don't worry.
So
and had a positive family history of asthma, but no response, and because no admission, he keeps in observation room until transfer him to admit. My question: can give him prednisolone? No, because he's the most important thing. The first thing to check his sugar. If he's DKA or not DKA. If it's not DKA and the sugar is normal or near normal, and you can what you can do is just give a nebulized or 10 puffs of salbutamol and open the chest. If you start hearing wheezing quite a lot, then it could be the asthmatic. And you can give prednisolone or hydrocortisone, but make sure because the sugar can bump the steroid can bump the sugar high up, and you'll be in a very difficult situation. But the most important thing, first thing, do the sugar, do the gas, and then look, is it metabolic or respiratory acidosis, and then you can manage them that. Okay. I will go remember to send your questions here. Okay. Now the compensatory. Yeah. Dr.
Someone was asking about a link, one of the links you shared, and I just want to tell them that this is being recorded, so you'll have the video, and if Dr. Nagi wants to share the slides, that would be excellent as well.
No, we'll put it. I mean, it's no problem. We can always. Yeah. The slides will be on Pediatric Index for Pediatrics. The videos will be on the YouTube channel for
exactly. We'll email you the link, and you will have all the information you had today. Somebody is raising their hand. Suhairi, I think. Do you want to ask on the mic? We prefer if you type it, please. If you type it,
yeah.
Excellent, yeah. It'll be quicker, that's why. Okay, who's next, doctor? If you go down to the bottom. In shock, what is the early to be abnormal blood pressure or pulse? I don't know. Somebody asks at 10:50.
Reluctant to consider, yes. I'm just going through the questions and I will answer if there's any question, not to worry. Thanks a lot. In shock, what is the early to be abnormal? Blood pressure or pulse? Pulse. Blood pressure late. Blood pressure is usually diastolic will go high and then suddenly it will drop. So the pulse will be the first thing always go high in shocked children, whether shock related to any cause of the shock. Some cases develop high blood pressure due to repeated nebulizer setting. Well, I think it can be the nebulizer can set the blood pressure, but don't worry because the nebulizer can make you have a tachycardia up to 200 or 210. The salbutamol is causing tachycardia, so the blood pressure anyhow will go high. But when you calm them down and the breathing is becoming less, then this will be going down. So as long as the blood pressure doesn't go diastolic, it doesn't go. Usually the systolic go high in the nebulized patient, but if they are shocked, then the diastolic will go high. If the diastolic it doesn't go high, don't worry. So the systolic will go down. Usually sometimes go to 150, 160, but not to worry. But if the diastolic reach 90, 100, and 110, then you have to do something. So that's right. So that's all. I think is all the questions. Probably give treatment of shock. Treatment of shock. As I said, is dependent on the cause of the shock. If hypovolemia, of course, the IV fluid. If it is distributive anaphylactic shock, you give the adrenaline IM, hydrocortisone IV, plus the nebulize, plus the IV fluid, and make sure the IV fluid for the distributive shock is different from the hypovolemic shock. So you don't bund them with a lot of fluid because they have a lot of fluid inside the body. So your treatment is to getting the fluid back to the to the body, but don't put a lot of fluid in them again, because we make it worse. And the cardiogenic, of course, you need to make sure the heart is pumping quite a lot in a good way. We're using the drugs, and then cardiologists will help you with that. Distributive is the same thing, like the and then you have the dissociative, which is the CNS, is related if the child is have a increasing cranial pressure. They don't need much fluid, so you have to restrict the fluid to 2/3 plus treating the cerebral edema, and you know how to treat cerebral edema, hopefully. We'll talk about it in due course as well. So that's the treatment of the shock. It's nothing. Okay. I think that's the drug withdrawal.
Somebody says, which better in assessment? I don't know, at 10:57. So just before my...
which better in assessment, Coach Koslu? Avabu. Avabu is a quick assessment A&E staff, but the Glasgow Coma Scale, the people, they use it in the same thing in intensive care or in the in a more setting, because this is quickly, you know, this is, you do it within 30 seconds to do this assessment. And Avabu is quickly, but Glasgow Coma Scale is there, and that's when they do neurological observations on the ward. The nurses always, they do Glasgow Coma Scale and they have a chart. But in A&E and in accident, always use Avabu. And if you go to do the courses, advanced pediatric life support or basic life support, then they will teach you how to use Avabu.
Nice. Someone says, in case of septic shock, what's the first step of treatment?
Septic shock, fluid, antibiotics.
Another one says, DKA, it's difficult because of cerebral edema versus the shock.
No, cerebral edema, it is, they usually come in a shock, which is fluid. And if you treat them, if you overload them with a lot of fluid quickly, so that's why DKA fluid usually distributed over 24 hours. So you need to, this is what I understand, that when I used to do a lot of general pediatric, you have to do it in 24 hours, the fluid, with the insulin and the board, and don't give bicarbonate. And this is what is the really guidelines. And if you, and then very, very good guidelines, if you go to nice guidelines, as I said in the slide, you will be find out. So DKA is completely unique management. It's not like the hypovolemic shock related to gastroenteritis. You have to be very careful with that. They have a different guidelines in treatment of shock in DKA. If you treat it quickly, then you get cerebral edema, and the cerebral edema is very bad, and it's very difficult to manage.
I think
treatment of shock in nephrotic babies, well, use albumin or normal saline. I think it's what you can use for nephrotic syndrome is we always, if they are really shocked, you need to use the albumin, and you use the albumin. It's not the high concentration albumin. It's 4.5%. I know, because when I used to teach quite a lot in the in PASS test, and I used to director of the PASS test for 10 years, I have one patient our slide on this nephrotic, and always we choose 4.5% albumin, give it on a longer time over 4 to 6 hours rather than normal saline. It doesn't. So you give the albumin, and then if they are dehydrated, then you give the normal saline as well. So that's what we teach all the time. Can we please yeah, EEG will come. I will give you full lecture on EEG. Definitely on EEG. Wondering about prophylactic guidelines for meningitis contact. Well, I think it's the household who's been with the patient, especially meningococcemia or pneumococcal, for more than 6 hours, they should have a prophylactic. If they are pregnant women, they give them cephalosporin. If they are not pregnant, give them Cipro. If they are not pregnant, give them the cephalosporins. And people who involved in the management of these patients, we never give we never give prophylactic to doctors or nurses or someone who's because of course in a hospital, because you are cautious, you're wearing a mask. If you think there is a meningococcemia, wash your hand and wear apricons. And then also if the patient wearing glasses or goggles, because if the patient cough or anything on your face, then if the patient cough on your face or you become in contact with their fluid, then you have to have the prophylactic. But we don't give prophylactic to everyone. Why dengue? I don't know what is said. What dengue and shock present with high dose? No, this is a compensatory phase because the first thing is come because of the adrenaline. If you go back and read about the physiology of adrenaline and dopamine and others, they always work on adrenergic receptor, and the first thing is getting spasms of the adrenergic receptor in the blood vessel. So that's why the blood pressure go high at the beginning. And then when the sepsis becoming more, then this adrenergic receptor is becoming blocked, and then the blood pressure will fall and the patient will die. Cefotriaxone is part of Cipro, so you give cefotriaxone or cefotriaxone. Cefotriaxone is much better one because it's once a day, and cefotriaxone is up to 3 times a day. So cefotriaxone is better. Both of them ciprofloxacin.
Okay, doctor, I think if there are no more questions, then it's probably a good idea to stop here. So a couple of things, please. Please let us know your feedback. I've put the link in there. And we also have this website called Index for Pediatrics. I've put the link to it, so you can follow us there. There is also a Facebook page. And regarding the new announcements, because we have your emails, we'll send you the emails. Please keep an eye on the Facebook page and on the Index for Pediatrics.
And the YouTube channel. We will send the link as well.
Yeah. And then all the videos, like today's talk, for example, will be uploaded to YouTube, so you can watch it again and forward it to others. Just wanted to mention something quickly, that some of your colleagues, many of them who have registered, have actually mistyped their emails, so the emails were actually wrong, and it wasn't possible to contact them. So please, if you in the future, when you see the announcement, if you could forward it to others, so we can have as many people as possible, just to spread the knowledge that people can benefit, that would be excellent.
One thing I just know, because we have 350 registered,
yeah,
and we have only 50 attended. I don't know if there is electricity problem in Libya.
Yeah, I think internet speed is a problem as well. So many people were trying to join. When I let them in, they can't join, and some people actually are joining now. So I think some people thought it actually starts at 11, maybe UK time.
Yeah. Excuse me, Dr. Nagi, can I ask a question?
We actually didn't want to have on the mic, but yes, since you've started, go ahead, please.
Oh, sorry, Malish, I didn't know.
Okay,
Dr. Nagi, you just explained that in the compensatory phase, there will be, through the adrenergic receptor, there will be increase of blood pressure. Why does blood pressure work on diastolic, not in the systolic?
Because of the spasm of because of the adrenaline, you know, when it's produced in quite a lot, it can cause a spasm of the arteries and small arterioles. So that means the blood flow will go down, and that's why the blood pressure. So that's why is at the beginning. And then when the sepsis, the marker for sepsis or the sepsis marker is reduced quite a lot because of the tissue damage, then they block this adrenergic receptor, and then the blood pressure will fall. So that's the short answer for that.
There is also a new question in the chat. If you could have a look.
Where is it?
There's one in the chat. 1105.
I don't know what does that mean. Biliary stenosis or something is.
Yeah.
Biliary stenosis is different. They have metabolic alkalosis, and they are different. And the treatment for that, the fluid is it is different from from anyone else. And I think it's using normal saline with the glucose to treat them, and always correct dehydrations before you're going for surgery. And that's the pyloric stenosis, because I know, and from the memory, they develop respiratory alkalosis rather than metabolic or respiratory acidosis. So they are different. So this means the pH will be high, carbonate will be high as well. So the IV fluid or the correction of fluid is different. So please go back and look for the how to do that as well. As I said, there's always on a nice guidelines. There is a quite few guidelines for fluid in pyloric stenosis.
Okay, I think we can wrap up. So from my side, Dr. Nuruddin, I'd like to thank you very much for joining us today. Again, just to repeat quickly, I've put the link for feedback in the chat. So please let's do your feedback. Also follow Index for Pediatrics and the Facebook page. We'll put some announcement there for you. And we'll email you if there's any upcoming lectures. We'll email you on good time. Please make sure you share with your friends and prepare in good time and join early enough. From me, thank you very, very much. And over to you, Dr. Nagi.
Then thank you very much for everyone who attended today. And unfortunately, some people who joined just now, remember that is we start in time. It doesn't matter. We start with 1 or 2 or 5. I will start exactly on time, and my colleague exactly the same thing. And then hopefully next Saturday, we will have the same people or more, even more, and we will continue. So we paid this room for 1 year, and then we will continue for a year, and then hopefully every Saturday we will have a lecture. Thank you very much for everyone who joined us, and thank you for and hopefully the one who didn't join us, hopefully they will join us next time, and then I will make sure that is we have the best lecturers, people who can deliver, and I will gather as many as possible experts to give lectures to you and to your colleague, because it's very, very important that is you have the our experience to be transferred to you. And if there's any questions or anything, please, we don't mind. You could write them on the Facebook, which was Index for Pediatrics, or you could write them on the email from the website, or from the also from the YouTube channel. Thank you very much, and have a nice day. And hopefully Libya will be safe one day. Then we can deliver these lectures face to face to you there in Libya.